Good afternoon, and thank you all for joining us today for our Men's Health the second of our Men's Health webinar series. We have with us today Dr. Laurence Sperling, who's the Katz Professor of Preventive Cardiology and founder of the Emory Heart Center for Heart Disease and Prevention. We're very privileged to have him here because he can kind of tie together some of what we're going to learn about today with respect to cardiovascular health and brain health. So with Dr. Sperling's expertise, hopefully you will glean something that will help you do a little bit better about your own health and safeguard your own health and your heart, and therefore your brain. Dr. Sperling.
Thank you very much for the introduction, Dr. Parker, and also for the opportunity to share with your attendees today during Men's Health Week. I'm going to speak about the importance of focusing on men's cardiovascular health, and not just during Men's Health Week. We really need to focus on health promotion and disease prevention every day, not just for men, but for women and for families and communities, because as I will point out, this is of critical importance. I just want to let you know I have no disclosures and no conflicts related to this presentation. The comments are mine and not related to specifically the organizations I work for, work with, or serve. Well, let's think back to the dedication of the National Institutes of Health. This was now 80 years ago. And by the way, it is called the National Institutes of Health and not the National Institutes of Disease. Franklin Delano Roosevelt said at this dedication, we cannot be a strong nation unless we are a healthy nation. This next slide here, the figure is from a paper we published a number of years ago. And this figure demonstrates what is called the health disease continuum. I can go back to the prior slide. There we go. So this is the health disease continuum. And if you look out here in red, this is disease that we often find late in its manifestations. And we certainly can care for individuals with diseases like heart problems, atherosclerosis, heart attacks, and strokes. But it's really important for us to focus here, which is those who are healthy and better understand what it takes to focus on health promotion and disease prevention. There we go. This next slide, I think, is one that I want all of the attendees to really get active in. And this is the American Heart Association's what's called cardiovascular health metrics. And by looking at these 7 metrics, you can calculate for yourself what's called your Life's Simple 7 score. And it's very simple to calculate. These metrics define cardiovascular health and not cardiovascular disease. So there are metrics related to cardiovascular risk factors, smoking, cholesterol, blood pressure, and blood glucose, and also metrics related to lifestyle and behavioral approaches like a healthy dietary pattern, regular moderate physical activity, and an ideal body weight. This table helps you think about for each of these categories, whether you have poor cardiovascular health, intermediate cardiovascular health, or optimal cardiovascular health. Data that we have from my colleagues at the Center for Disease Control and Prevention through a behavioral risk factor and surveillance survey in over 350,000 Americans by self-report tells us that only 3% of Americans have ideal cardiovascular health. About 10% of Americans have poor cardiovascular health, and we know there are large disparities by age, gender, education, and ethnicity. This is a figure from our National Vital Statistics report in 2015, and you can see at the top of why men die in our country, cardiovascular disease or heart disease, certainly an outlier. Now, I know this webinar is sponsored by the Alzheimer's Brain Center at Emory, and we know there are many other chronic diseases that are causing deaths in American men. But if we look at Alzheimer's disease plus the deaths from prostate cancer, these deaths combined equal the deaths caused by the number 5 cause of deaths in men, which is stroke. The center that is hosting this webinar, I know they focus on brain health. And this is a paper that was published just a month ago that really ties together that heart health is brain health. Essentially, vascular health is heart health, brain health, and really translates to cancer health as well, or cancer preventive efforts. In this paper, the investigators looked at 1,600 individuals who are already at the age of 80 and followed them out for 20 years. None of these individuals had dementia, and they did a yearly evaluation of brain health, essentially, looking at their thinking, cognition, memory, working memory, and then also the speed of perceptual recall. And here in blue, those who had the lowest heart risk scores tended to do the best over 20 years in this already older population in all of these metrics. As a cardiologist and as a preventive cardiologist, we often think about traditional cardiovascular risk factors: high blood pressure, cholesterol abnormalities, diabetes, smoking, obesity, poor diet, and physical inactivity. Well, these traditional risk factors explain part of, but not all of, cardiovascular risk and vascular risk. This is from a paper we published a few years ago, and it points out that our socioeconomic status is a great predictor of our risk for disease and also a predictor of our health. And we need to think very differently as we approach addressing traditional cardiovascular risk factors versus socio-demographic factors like poor access to care, healthy foods, psychosocial, behavioral, and environmental factors, because our interventions are quite different. Here, more focusing on behavior, community, education, and then at the level of policy. Well, this is Men's Health Week, and as I mentioned, we need to focus on the health of men and cardiovascular prevention, not just this week, but every day, because men are less likely to seek medical care. They're half as likely as women to go to the doctor. They're 3 times as likely to go 5 years without a doctor's visit, and they're twice as likely to never have contact with a health professional. Luckily, men that have a partner and social support, for instance, married men or men that are part of a family that's supportive, tend to have a better chance of receiving and following up with regular medical care. So I do think the future of cardiovascular medicine, it has to be a greater focus on cardiovascular health and prevention. Since October of 2019, I have had the honor of serving as the executive director of a national initiative called the Million Hearts Initiative. This initiative is shared by the Centers for Disease Control and Prevention and the Center for Medicaid and Medicare Services. It was started in 2012. The ambitious goal of Million Hearts is to prevent at least 1 million heart attacks, strokes, and cardiovascular events among Americans. The 3 pillars of Million Hearts are keeping people healthy by reducing sodium intake, tobacco use, and increasing physical activity. This is more at a population level, although we should do this as individuals, realizing at a population level, this is really getting down to where we live, work, play, and learn. Million Hearts focuses on optimizing care. This is focusing on the ABCs: appropriate aspirin use, blood pressure control, cholesterol management, and smoking cessation among those with heart disease and those with risk. Increasing utilization of cardiac rehab, focusing on heart healthy behaviors, and improving outcomes for priority populations. Our 4 priority populations, although there are many priority populations that we focus on, are African Americans with hypertension, the 35 to 64-year-old age group, because in this age group, we see a really disturbing increase in cardiovascular events over the past decade. 2/3 of the counties in the United States in this younger age group have increasing heart disease and stroke rates and mortality. We focus on those who've already had a heart attack and stroke, and those who have mental and substance use disorders. Again, I thank you for the opportunity to speak to those on the webinar today attending this important Men's Health Week session. And I'd be absolutely glad to address any questions or comments.
Thank you, Dr. Sperling. There are some questions in the chat. One of the things that you spoke about was that poor people have regular risk factors like high blood pressure, diabetes, and other things for heart disease, but you talked about lower socioeconomic and educational status. So for people in that category, are you saying that in addition to medications, we have to do something else to help these people?
You know, most definitely. You know, we often conceptualize that health and disease are determined by our health systems, our healthcare systems, and really only about 20% or so of health and disease are determined by traditional healthcare systems. And so really health happens out there. Out there is where we live, where we're born, where we live, where we work, our communities. It's where we learn and play and pray. And so there are significant disparities in health and risk for disease in our country. And these are disparities that right now in the setting of a pandemic, we are learning that these disparities are playing out. And we have vulnerable populations where we have to recognize that we need to invest in health across the populations to create equity at the level of policy, support, and a lot of the support is at the level of the community, interfacing between health systems, our community, and public health.
Okay. How can, you talked about the organization Million Hearts, somewhat familiar with it, but can anybody who's on this webinar become a part of Million Hearts? Is that something that we can be a part of? And what does it exactly do?
Sure. So Million Hearts was started in 2012, and it's explicitly a partnership between the CDC and the Center for Medicaid and Medicare Services. This is a national program. Million Hearts has have over several hundred partners across the country. These are organizational partners. We work across all 50 states and territories of the US. As an example, this week we had a meeting with the National Association of Community Health Centers. There are 1,400 community health centers in the US that help serve 24 million Americans in terms of health, promotion of health, and disease treatment. And so our network is across the country. As an individual, I think it's important you realize that there is this Million Hearts initiative. I want all Americans to be aware that there are millions of hearts at risk, and that we can't wait until an event occurs to take our heart health seriously, that each and every one of us needs to understand our risk, focus on doing something to improve our risk, understanding our family history, and partnering and becoming a part of our care with our care team through shared decision-making. Heart Month in February was focused on hypertension control in African Americans at the CDC. Our push and our slogan was, "Together we've got this," which means heart risk factors are identifiable and they're treatable, and the majority of heart problems, risk for heart attack and stroke, that's preventable.
Okay, I agree with all of that. What are the ABCs? And if it's at all possible, can you pull up that risk factor slide with the body mass index and other things that people needed to be aware of? Like that checklist for am I at high risk or low risk for heart disease?
Absolutely. So first I'll talk about the ABCs. As far as pulling my slide back up, I mean, if I can have the slide deck back up, I can dial back to that slide, but I think I've got it in my brain anyway. As far as the ABCs, this is just a construct related to the medical and public health term would be called population attributable risk. And so we know by making modest changes in risk factors that can be treated through evidence-based proven therapies across the population, we can prevent thousands, hundreds of thousands, and million cardiovascular events. The ABCs stand for appropriate aspirin use, definitely in people with known cardiovascular disease. For those who are in primary prevention, there we have to really call into question the risks of aspirin versus the benefits. And this should be something to talk to your clinical team about. Blood pressure control. Blood pressure control in our country has been flat over the last 10 years, really at about 50% or so. And we know many people are aware they have high blood pressure. They're under treatment, but their blood pressure is not being optimally controlled. The C is for cholesterol management, and we know there are low-cost medications available in addition to following a healthy dietary pattern that can not only lower cholesterol levels, but significantly affect heart risk. And S is for smoking cessation. Despite our country making some really great strides in tobacco use and also in secondary tobacco exposure, about 18% of Americans still, 15 to 18%, depends on the population, still smoke. And just maybe 2 months ago now, the Surgeon General's report on tobacco cessation was released. This was the first Surgeon General's report specifically on tobacco cessation in over a decade, maybe several decades. And so we know at every stage of life, quitting smoking has significant benefits related to the reduction for heart attack and stroke.
And this is going to be the last one about daily aspirin. You said appropriate aspirin use, okay? So people who have angina, congestive heart failure, there are probably people who need to take aspirin, but what about people who are somewhere between 50 and 75 and they're healthy, they don't have high blood pressure? Should they be taking an aspirin every day?
Yeah, so first just to ask, I guess, to answer the second part of your prior question, the traditional heart risk factors that you should be aware of are high blood pressure, high cholesterol or abnormal cholesterol, smoking, diabetes, obesity, physical inactivity, and an unhealthy dietary pattern, as well as your genetic risk. To answer the question about aspirin, this is a complicated answer. For each individual, you want to know your risk. And unless you're a very high-risk individual, in general, aspirin for primary prevention has a higher risk of a side effect than a benefit. The medical term we use is net clinical benefit, and that's the potential benefits versus the potential side effects or risks. So here I would say talk to your physician or clinical team, raise the question. There are still people who are primary prevention patients who are high risk, who have a low risk of bleeding, where the benefits of aspirin outweigh the risks. But I think using aspirin every day to protect your heart comes with the risk of bleeding.
Thank you very much, Dr. Sperling, and thank you so much for taking the time to be with us today. And we look forward to hearing more from you. And I guess we're going to get some more information about Million Hearts and the CDC's initiative on heart health with CMS. Thank you.
Thank you very much. And again, thank you for the opportunity to speak on this webinar.